So now we are moving to the last panel before lunch, and it's about placing PrEP in perspective, ethical, sociological, and community views. The moderator will be Julie Barroso from the University of Miami, and the presenter is Jeremy Sugarman from the Johns Hopkins University. So the moderator will introduce later the discussants. Julie.
Great. Thanks very much, everyone. And ethics before lunch. It's great. I actually appreciate the opportunity to talk about one of the things I love to do, which is to talk about ethics related to HIV and AIDS. And I think it's critically important as one of those disciplines that's important to bring into the conversation that hasn't been here yet. I was given 10 to 12 minutes to talk about the ethical issues in PrEP, and as you're probably aware, ethics is not one of the things that really lends itself to sound bites. I'm going to do my best to introduce a series of topics rather than take on the really meaty task of addressing each and every one of the issues, which we could go into in great depth. And also, given the state of flux with PrEP, as we've heard with what's known, what's not known, and all the unknowns, there's so much that we could deal with. So I'm going to address initially some of the ethical issues on the use of PrEP, and then touch on the ethical issues with research and justice going forward. And then the panel's going to engage and sort of beat up on me a little bit, I hope. And then you can go to lunch and continue the discussion. So with use, one of the sort of ethics favorite pieces is to talk about this notion of choice or liberty of individuals as well as well-being. And those are frequent tensions as well as fairness that come up with many ethical issues regardless of the venue. We'll talk about research and allocation. Choice and liberty is critically important to individuals, and we couch that in ethics language because it enables, and the neat thing about PrEP is that it enables individuals at risk to take preventive measures for their own. It doesn't rely necessarily on the actions of others. So when we treat, which is a good thing, as when I wear my white coat instead of my dark philosophy coat, and I'm seeing patients, I sort of like treating people. I mean, it's sort of a good thing. But in the sort of day-to-day life of people who are maybe not patients and they are going about being individuals in the world, they can be empowered when they either know the status of their partners or don't to make choices. And that's a critically important function of PrEP. It can also be discreet. Now, we did hear some of the issues about, carrying around a bottle of Truvada can be problematic, but the issue is you can be discreet in relationships, and you can be discreet in that setting. So it's not that it's stigma-free, but that empowering part is critically important that, say, treatment as prevention, in that when it's used that way, doesn't give you. It also enables episodic prevention, and that's also critically important. While we think about it, there are periods in our lives. It sounds like Australians only boink on holidays, from what we heard this morning. Others maybe to go on weekends, or periods in our lives where we're very sexually active and other periods where we're not. Jet lag is terrible for that, So not that I'm looking across the room and seeing why you're tired. I don't know why you're tired, but you can answer that yourself. Be discreet. But episodic prevention can be important. For well-being, this question is debatable, right? Well, we didn't see in the early trials this necessary increase in risk behaviors, but we don't know, as many presenters pointed out, what's going to happen as PrEP is used. Well, it's rolling out slower than we thought, but really what's the behavioral aspects when there isn't the consistent counseling? If general internists or family practitioners or other clinicians are providing the counseling, will that be the robust nature of sort of the counseling that accompanies clinical trials, the cheerleading that goes along with it? Unprotected sex, additional partners, or riskier practices. I don't want to debate the different psychological models, whether it's risk compensation or behavioral disinhibition. The fact is, if risk behaviors change, is it possible to overwhelm the preventive efficacy? We don't really know that piece. And other STIs, as has been pointed out, some are treatable with antibiotics and others are not, or some have very effective treatment. So these are issues that accompany safer health practices or sexual practices beyond the issue of HIV, and critically important to the health and well-being of individuals. Well-being and resistance. Obviously, this was important and a concern within the early trials. Again, fortunately not seen, but again, as we roll out, what's going to be the possibility of the effect, and the idea that we have now a risk mitigation strategy that's part of the Truvada marketing, at least under the FDA in the United States, is one way of capturing that to make sure at a population-based level as well as an individual level that this resistance doesn't develop, because we don't need to be battling resistant virus in addition to the other problems we have. So it's probably too soon to tell, and just watching it's not bad to watch. Side effects, we heard earlier. What's the initial rollout? I mean, one of the challenges to an episodic treatment is the worst parts, the first few weeks to months. And if you're using it episodically, and that's exactly when you want to use an agent, at least with what we have known right now. Again, other agents moving forward, we don't know if this is going to be the same profile ahead. For parameters of use, a little bit of discussion as well. The use of, we think other antiretroviral agents will be useful, and there are several studies on board. So HPTN 069, we should have the results fairly soon. We have other modalities that we heard discussed, vaginal rings, we're going to have gels, we're going to have various different alternatives. But for right now, in practice, not in research settings, but in practice, it would be ill-conceived to recommend the use of ARVs without demonstrated efficacy. At least in trials. I'm not even talking about effectiveness. Using alternative dosing schedules without demonstrated efficacy and safety poses potential hazards to the individual. Using without appropriate screening, especially starting therapy when someone comes in, is really critically important. Are you really negative when you're starting? Seems to be a crucial moment on which there's important considerations. And using without other HIV prevention services. Stigma. What does the bottle mean? Hold it up. What's the bottle mean? Taking an ARV. I'm taking it to treat myself. I'm taking it to prevent it. All good things. All good. What does the bottle mean to someone else? Does it mean that you're promiscuous? And is that a good thing or a bad thing? Does it mean, as we would hope it would mean, that you're taking measures to prevent yourself from being effective? Or does it mean that you're too promiscuous and that you need to have this method? What does that mean to relationships? It's really unclear. We have some competing notions that come up. What does it mean to insurability and employment for places where health care is not available to everyone? And we also heard this notion of criminalization in different ways, or how that plays out. So critically important about what it means to be carrying around a pill of anything. Diversion. This hasn't been as much of an issue as we thought, as increasing rollouts taking place, about the ability of taking a prescription for PrEP and giving it to others who are well off. Here to say, I just wanted to put it up there for completeness, because if a single agent is used, or two agents are used for treatment of people who are early HIV infected, obviously not a good thing in the treatment of those individuals. So considerations for research, shifting gears now. We have a lot of exciting modalities that are being tested right now. It's really interesting to hear the range of trials that are going on. Cheryl touched on some. It was amended by others in the room about the variety of things that are being tested right now. And this is going to be really interesting to see, first, what are the ethics of these trials? Alone is going to give us a lot of information, and many of those trials are closing down soon. So it's going to be really exciting. Hopefully we'll have a menu of options. But we're going to also learn about PrEP more broadly, which is fantastic. But going forward for the next generation, and we have some great issues of, say, that we're addressing now in 2 HPTN trials that are going forward with long-acting injectables. Like, wow, an injectable. So you have a side effect from that drug. Can't get rid of it. What do you do? So there's certain components of that fix the compliance or adherence issue, but raise some other issues about drug safety over time. Those current trials are going to be done in populations who are not at high risk of infection, but eventually the product's going to roll out in other settings. And so the resistance patterns and the like, really interesting and important components. Monoclonal antibodies, when they come down the pike, how would those be administered? What's that going to be like? But the control arm going forward for the next generation of trials, remember, virtually all these phase 3 trials were placebo-controlled. Placebo controls are great because you can better show efficacy, you can better show safety, you have a smaller sample size, means faster to answer. Is it appropriate, now that we have oral PrEP that's available, to be using placebo controls going forward? I don't have enough time to talk about it. Sorry. Great questions, though. And also the standard of prevention. We have other modalities of prevention, and we are talking about cascades and combination prevention and the like. And so how in this world that's moving so quickly, when our primary obligation is to protect and treat those who are infected and those who are at risk, what's the appropriate standard of prevention in a trial? The old days, it was condoms and counseling. What's supposed to be part of the prevention package afforded to all people, and what does that do to the ability to conduct trials the way we know them? So those are the interesting set of issues to think of for going forward. Finally, allocation. Allocation, even among HIV, there's a bit of a heated literature on this issue about should ARTs, when ARTs are limited, how ought those ARTs be allocated? Should they be allocated for other forms of prevention, such as treatment? Or should they be used for other modalities? Should they be used for treatment versus prevention? How do we decide how that pie is divided up? I didn't mean to say pie right before lunch, sorry. And pies here, for those of you not from the UK, are different pies than the ones that we get in the United States, so not quite as sweet. Other health needs as well, and also for research. So this continuing cascade also important. So finally, what I hope I've shown you in my few minutes is that evolving data support the use of ART for antiretroviral agents for the prevention of HIV. Nevertheless, there are a set of ethical issues, and hopefully if we're aware of these issues and keep the problems on the table, we'll stand a better chance of addressing them. So thanks for your attention. I look forward to seeing what everyone else has to say.
Thank you. Is this on? Yes. Thank you, Jeremy. We really appreciate that. So often I think we get ahead of ourselves in our clinical work, and then the ethical issues come up and we have to get those two aligned. So we really appreciate your talk. Our first discussant is Sheldon Fields. He's from Florida International University in Miami, Florida.
All right. Good afternoon, everyone, and thank you for the organizers for the nice invitation to hop across the pond to be with you. So I have multiple perspectives as a researcher, healthcare provider, policy analyst, community member, and a self-identified black man who has sex with men. So the epidemic in the United States will really never be impacted if something is not done to address the disproportionate impact that it has on the MSM population. More specifically, we really have to address the population of black men who have sex with men who are vastly disproportionately impacted, with incidence rates similar to those only found in sub-Saharan Africa. Then again, when you look at the young black men who have sex with men, those between 13 and 24, and we've seen their HIV incidence continue to increase year after year. And this is where I think we have truly failed, particularly in the United States, and why I also think that the implementation of PrEP in this subpopulation of men who have sex with men is really an issue of social justice. And that's where the ethical piece in this discussion really comes in at. We have proof of concept that PrEP works. So the task now is to find the most optimal way to implement and scale up the use of PrEP, particularly in young black MSM. So what are we going to do about it? We have just completed enrollment of 225 black men who have sex with men, nearly half of whom are under the age of 25, in the HPTN's 073 Vanguard study, which is a study that is investigating the initial uptake and adherence of PrEP. A key component of our study, HPTN 073, is the client-centered care coordination model that is being used to begin to address the very real-world issues that black men who have sex with men deal with. We know that from previous studies that black men who have sex with men cannot simply be given a pill and expected to adhere. We have to simultaneously also acknowledge and mitigate those social determinants of health, historical discrimination, and stigma that continue to adversely impact black men who have sex with men in the very real world. C4 is a part of this intervention which is designed to begin to address these particular matters. The bottom line is that for black men in the United States who have sex with men, HIV is still a raging epidemic, and we must use the multiple approaches all along the treatment's cascade to impact the epidemic. Hence, in terms of prevention, because we know it works, PrEP must be included as an option for black men who have sex with men, and we have to continue to find ways to optimize its use, especially in this highly disproportionately impacted risk groups. And we simply do not have the luxury of time to sit and ponder all of the ethical considerations, but we must consider those in a very real-world context. So on that perspective, we know it works. We have a highly impacted group, which we've not been doing enough with. And on that note, I'll end. Thank you.
Thank you, Sheldon. Thank you very much. Our next discussant is Jim Pickett from the AIDS Foundation of Chicago.
Good afternoon. Thank the organizers for having me. Just to give you a little background on my perspective, my title might not fully describe that. I work a lot on new prevention technologies around the research and advocacy for them. We're doing a fair amount of PrEP education and training in our communities and with the HIV workforce. And another hat I wear is the chair of the International Rectal Microbicide Advocates, IRMA. So rectal microbicides are super important. We all have that compartment. Many of us use that compartment, and it needs protection. I would also like to just quickly thank the AIDS Healthcare Foundation. I was delighted to see that they were sponsors of this event. And also just to thank them for mobilizing literally thousands of new advocates for HIV prevention and PrEP. I can't say I understand the incredible efforts that this organization has taken to oppose PrEP, but I think the scaremongering, the paternalism, and the false information that's been put out by AIDS Healthcare Foundation around PrEP has really mobilized lots and lots of people. We're seeing lots of HIV-negative gay men in the United States who are really involved in prevention and PrEP advocacy that we've never seen before. So I'm delighted for that. So thank you to the AIDS Healthcare Foundation for that. I also want to now just give a few points from the U.S. rollout, some of my perspectives about the U.S. rollout. We've talked about this a bit, but I think linking PrEP, Truvada as PrEP, to healthcare access is really the key, and healthcare in a holistic way. The new chief of the HIV/AIDS division in New York City, Dimitri Daskalakis, calls Truvada the gateway drug to primary care, and I couldn't agree more. And it's not just about sexual health services or preventing HIV, it's full, robust health care. And imagine getting people into health care, PrEP or not. PrEP could be the carrot, it may not, but everyone needs full access to full, holistic health care. And we've talked a little bit about cascades. We're very much behind a cascade for HIV-negative individuals. Why do we only have a cascade for positive folks? Let's engage people when we test them, and if they don't have health care, let's get them into health care. Offer them PrEP if that's something they need. If not, we can provide them all kinds of things, not just things that need to happen between their navel and their knee. That said, there's some serious issues, right? So we have the expansion of health care in the United States, but about half of our states did not expand Medicaid, which is our program for poor people. The Affordable Care Act has provided regulations to improve insurance and has provided increased access to insurance, but there's still a lot of problems with it. With all insurance, the devil's in the details. If you have high premiums, high co-insurance, high co-pays, you cannot afford to be on Truvada as PrEP. So cost is an enormous issue. We're seeing insurance companies playing tricky things, putting HIV drugs into specialty tiers that cost a lot extra. So this impacts people living with HIV like myself, and it impacts people who want antiretrovirals like Truvada for prevention. So we have been working and pushing Gilead to be more generous with their support programs. They have a medication assistance program. They also have a copay program. Those things could be more generous, and we hope that they make them more generous. And of course, the overall cost could go down. We'd be really happy about that. It's $15,000 a year in the United States. We pay the most of any country in the world, and it's a crazy amount of money. So we're also seeing significant issues with provider misinformation. We've talked a little bit about that today, providers who don't know about HIV or PrEP. So they need to be educated. Community misinformation is also an issue, so we're doing a lot of work in communities, and it's critical to get to the folks Sheldon's talking about. We need to find the people who are most vulnerable and make sure that they know about PrEP and have access to it, and I don't think we're doing a great job of that yet. And then certainly misinformation among providers and communities is not helped when there are organizations putting out things that are misinformed. Finally, we also need to work on structures and policies to improve PrEP access. You can't just sort of hang up a shingle and start delivering PrEP. We have siloed funding streams in the United States that divide PrEP and treatment as separate things, and now that there's this blurring, we need to sort of bust those silos. There's been some interesting work. Washington State has a PrEP drug assistance program run by the state. Yesterday in San Francisco, people were calling for the city to start providing support for PrEP, so that's a really good thing. I'm going to conclude my comments with just ways that I think we can frame PrEP. We hear it framed in so many ways, and I think PrEP is safer sex, PrEP is protected sex, PrEP is responsible, thoughtful, proactive, and disciplined. It's careful, it's healthy, and it's effective. And it also allows for intimacy and pleasure. It reduces fear. It increases peace of mind. Peace of mind, it's not a side effect we often talk about. We talk about the GI problems. We don't talk about peace of mind. That's actually really critical. Imagine having fear taken out of your bedroom if it's been in your bedroom forever. So the final things I'll say is PrEP is great because it doesn't need to be taken in the heat of the moment. It doesn't need to be negotiated. It can be taken with your coffee in the morning when the lights are bright and you're watching the news. It's not forever. It could be for just a period of time in your life. It puts the negative partner in control, and it puts the receptive partner in full control. And then I'll conclude by I don't know if PEPFAR is still in the room, but there was a list of right things that were put up on the screen yesterday. I hope that list of right things eventually, or not eventually, tomorrow includes PrEP. Thank you for your time.
Thank you. Thank you so much. Our next discussant is Midnight Punkasetwana. He is from the Asia Pacific Coalition on Male Sexual Health from Bangkok, Thailand.
Thank you very much. This is on. Okay. Good afternoon, everyone, and thank you for the organizer for inviting me here today. I'll be speaking primarily on the MSM perspective from Asia, because I think we've not heard a lot of information coming from the Asia region. To put things into context, I've been working with UNAIDS in last year, 2013, and we did a MSN fact sheet that was launched at the international, regional international AIDS conference. So the stats that we have are in Asia region, the prevalence of MSM is estimated to be more than 5% in many countries such as China, Indonesia, Malaysia, Thailand, Myanmar, and Vietnam. And most of that, the prevalence is concentrated among cities. So we are looking at more targeting interventions in, say, Bangkok, Hanoi, and Jakarta. And the estimated populations of MSM in the region is between 10.5 to 27 million. So that is substantial. However, in terms of investment going into those populations, it's less than 7% of the total HIV prevention being spent on MSM. And further, fewer than half of MSM surveyed in 2012 in 6 cities reporting using condoms consistently. And the median coverage amongst 12 reporting countries is only around 60%. So how is this relevant? The Commission on AIDS in Asia in 2008 predicted that by 2020, the majority of new HIV infection will be amongst MSM, and that is the trend that we're seeing now. So PrEP, as recommendations in the WHO guidelines, was very much discussed at the Melbourne conference, because in our region we never had a chance to discuss this within the MSM in a broader context. So with WHO, APCOM, and UNAIDS had a little discussion, satellite session on how do we roll this out in Asian context. So we're working together with WHO in CERO and WHO WIPRO to look at the ways that the communities such as APCOM can involve our constituencies, working with the communities on the ground, and also reaching out to other younger communities who are online and on social media to be involved in this discussion. And what we find that primarily the reason why people don't talk about PrEP is because they don't have the access to those information in their own language. A lot of discussions here is mostly in English. The guidelines are in English and very big. So what APCOM is trying to do is actually reducing the complexities of what the guidelines is talking about, and then looking at translating those into languages that our advocates, people on the ground, can actually understand and be much more involved in that discussions. I also want to talk more about the reaching targeting messages to the younger people, younger MSM, and in a way that they would like to have that information access. So I think the previous oral session talked about the campaign. So how do we make it more sexy, ensuring that people can access those information in a way that they like to be accessed, in a way that they find it a bit more engaging. So within, just to give you an example, in APCOM, we are currently doing a regional young MSM HIV testing campaign. We're starting off with Bangkok, and we have using the younger MSM to help with the messaging and targeting. And their message that they want to put out is called Suck, Fuck, Test, Repeat. And that was, it was an instant kind of like viral success. And there was videos that shows quite explicit, sexual activities. But it's a way that actually is engaging to those populations, and it's a way that they actually share it out and talk about sex in a way that's not stigmatizing. So to conclude, I think about ensuring that we target populations that we want to target, and in a way that those messages get to those populations, and making sure that the information that they have is in a language and in a way that it can provide information feedback to these more global discussions. Thank you.
Thank you, Midnight. We appreciate that. Our final discussant today is Janet Seeley. She's from the London School of Hygiene and Tropical Medicine.
Thank you. My other identity is as the head of the social science program for the British Medical Research Council research on HIV. So I'm in Uganda a lot of my time, and I think I just want to respond to some of Jeremy's comments by reflecting on some of the reality of life in Uganda. And a lot has been said, and I realize I'm between you and lunch, so I'm not going to go on very long. But I think that one of the things that Jeremy picked up on was that PrEP is discreet, and it is the individual protecting her or himself. And I think that yes, that is, but it also the context, as Dana had pointed out this morning, is so important, because it may seem to us to be discreet, but actually just the fear that you know you have the drug somewhere in your room, and maybe somebody will find it, doesn't make it discreet. And I think understanding the barriers that many people still have to going for ART, even when they are sick, helps us to understand the barriers also for PrEP. Because if as has been said, ART is treatment, then ART as prevention is not easily understood. And then, therefore, there must be something wrong with me if I am the one who's got to take the drug. So I think thinking about context is important. We work with 2,000 female sex workers in Kampala, and one of the things that is so important to many of those women is alcohol, because how do you do the work if you're not got the comfort of a drink or two? And I think the reality of, rather than some interventions that are trying to cut back on drinking, is to look at how that can be accommodated, because that's a real necessity for some of the work. I know that's not necessarily a popular view, but I think it's naive to think that you either stop people from doing sex work or you stop people from drinking, when it's an economic necessity to sometimes do both. So recognizing that drugs need to be a part of that reality, the context of women's lives, which is why the ring, these other interventions may also be important. And just coming to the ring, we're also involved in ring trials. I think one of the interesting things is that, for me, and David will probably remember this from 30 years ago in Uganda as well, people were worried about condoms being lost inside the woman. That's still a fear nowadays, and women are now in conversation. What happens if the ring goes inside? What happens if the man feels the ring when he's having sex with me? What's going to happen to me? It's those real worries that stop PrEP from being discreet, which I think we need to take into account. So it's great PrEP works. It's great that it's something that we have, but it has to be, as many speakers have said, part of our array of things that are on offer. It needs to be provided with information and understanding, and it needs to be supported. And my main plea, I suppose, is for the funding always to be in these trials for the appropriate behavioral and social research. I'm an anthropologist. I'm happy I'm here. So, you know, it's happened very recently to me that there's been a funding cut on a trial. What goes? The thing that's relatively easy to go, it's the social science. And I don't think we can understand what is going on in people's lives if we don't make sure that's properly funded. Thank you.
Thank you. We have just a few minutes for questions. Does anybody have any question for, wow, a lot of people have questions. If you could, he's coming with the microphone, if you could.
Hi, I just have a question around sort of PrEP practically going into the future, or any intervention around kind of incarcerated or prison populations. I remember when originally the needle exchange programs were very clearly effective, one of the biggest barriers was getting it into prisons in many places, and some places never. And lots of the talks before talks about how many incarcerated, how many people who have HIV already incarcerated. So presumably quite a lot of transmissions happening in prisons in the US. So how would you envisage PrEP being allowed into those areas in the future, or is that possible?
So yeah, nobody locks up people better than the United States. We do it really well. And we do it disproportionately. So again, men of color are disproportionately imprisoned in the United States. And part of the intervention that I was talking about, this sort of client-centered care, we have good colleagues out in LA that have really fostered a relationship with the correctional industry, because in previous trials, people would get incarcerated, but they had a tie back to the study. The one person was helping them navigate in sort of real-life world issues, that when they were in the system, they got a call, so we knew where they were. And the moment they're released back out, one of the first things they did was came back to the study. So it is very real, and we do have to deal with it, particularly in some of the most highly impacted populations. But it's all about how do you partner with the correctional facilities and work with it, because we're not going to stop locking up people.
So, Jeremy, nice seeing you there. I have a question for you. David Soda from Uganda. Uganda, as you know, was one of those countries that participated in PrEP. And actually, TASO, which I'm a chair of the board of trustee, is one of those organizations. The clients there and their partners have really looked for PrEP. But Uganda government has actually indicated that this is not their priority. It's not going to really try to promote programs on PrEP at this point in time. So the question is, ethically, to what extent what are the ethical imperatives for us in trying to do demonstration trials for PrEP, knowing that at this point in time, the government we are dealing, is not pushing forward for this?
Great. So thanks for the great question. And I applaud your continuing to work in an environment which is challenging with respect to all sorts of HIV/AIDS prevention activities and treatment. So I applaud that work, and on the ground what can be conducted safely and properly at the same time generating data. So in conducting or thinking through the prospects of gathering the data that might drive policymaking, and we would hope that data would drive policymaking among governments, it's essential to make sure that the participants in those projects are maximally safe, and that doing the research that's necessary doesn't put additional risk upon them that would undermine all the good that would be done in the end. So if you can construct a world in which the participants are safe and willing to be engaged, then I think gathering those data are essential, because I think what we know is that it's not one epidemic, and it's not one epidemic in any nation. There are sort of micro groups that could presumably benefit, and there's been some good discussion in the ethics literature about the potential for PrEP, especially important among groups within Uganda that may get missed if all the resources are put simply to treatment. And it's to take care of the least well-off. And you're hearing a common theme here about empowering the least well-off or the vulnerable in certain ways, or those who have suffered different kinds of injustice. And so that aim is the aim of, I think, gathering those data to be able to provide that and provide the protection.
I think we have time for one more question. There's in the very back.
Hi, Lisa Power. In some ways, it's actually a carry-on from the last conversation. We know that in some countries, we've talked a lot about the embarrassment or the stigma of being found with the pill, but actually getting the pill in the first place can be incredibly difficult. There are a number of countries in which some of the key populations who are most at risk are criminalized, and in order to get hold of PrEP may have to disclose sexual activity or commercial activity which would render them reportable to the authorities. That makes it very difficult. And we also know that one of the very biggest causes of men who have sex with men not accessing treatment and likely not accessing PrEP is having to disclose same-sex behaviour to clinicians who may themselves be prejudiced around MSM. Never mind what the law says, it's how people are treated in the clinic. And I think that if you're going to be really serious about PrEP advocacy, you also have to be serious about advocacy to reduce prejudice within the medical services against certain key populations. Thank you.
Thank you. And it is lunchtime. Thank you all so very much for participating. We appreciate it.